Good morning, Sawadee krap. This morning, I'm just going to be the seat warmer because the real important person is next to me. But what I like to do is for those of you who might not know who Bumrungrad is, to just give you a little bit of background behind us. Yeah, we've just entered our 40th year of operations this year, so we've been around a bit. We've got accreditation, so quality is really important to us. We've been JCI for quite some time, since 2002, and like I said, quality is really important to the hospital and to the management of that. We're a fairly large-sized private hospital, 580 beds, a lot of outpatient clinics in terms of outpatient ambulatory care. We've got a lot of patients coming to visit us, over 1 million patients a year, and the difference about this is that we have about 50% of our patients are actually overseas patients, so they're not Thai patients. They're from all over the world, 190 odd countries. Yeah. We have a big group of people working for the hospitals. You can see the numbers there, huge numbers in there, right? Today's competition, I mean, in today's environment, and all of you are hospitals, and in a certain sense competing for business, yeah, in your own markets. What do we have to do to stay ahead, or to go to the front? In most cases, and that it's changing a little bit. In most cases, people come to the hospital because they have to. It's not because they really want to. Yeah. They have to. And so you want to actually leave them with a good experience at the end of it all. How do you improve patient experience? By ensuring that the quality of care is good, the service that they receive is good, yeah, and the outcome is good. And that's how basically we believe you can actually improve patient experience. And that really is summarized by our vision and mission statement. I'm not going to read it because I'm sure you can read, and I don't want to spend the time doing that either, right? Right. What we did, hang on, did I go too fast? Yeah, okay, that's correct. What we did was, sorry, that is correct. Yeah. What we've done is that we've learned about HBI, and together with them, we've done a proof of concept within the hospital initially, and that's what we've done. And we looked at doing things with sepsis prediction, which Chris actually quite well elaborated earlier, on mortality, length of stay, and some population analytics. That's what we've done. What I did was, we saw this a year ago at the 2018 Global Summit. And what I thought was that, gee, that's really neat. I think something that we could bring back to Thailand and out. And so I actually introduced it to the executives in the hospital, and we agreed to do a proof of concept. And that's where we got together and started working on that. Just a bit of background. That's what happened. We met them at the Global Summit. We started a POC with them mid-December. They took the data from us, track care data. They did the machine learning. They presented to us the results in terms of the clinical sepsis and mortality. We found it of great interest, but we had we had some pain points. And one of them was actually managing cost and cost predictions, or rather price predictions, estimation for the patients. And so we spoke with Eric, HBI, and then they said they could also do that. And so what we've done is we've actually gone ahead with an extension of the proof of concept, and actually gone into a price estimation algorithm using machine learning. And that was just presented just yesterday to us. Right? And that's all I really want to say. That's where we were, that's what we've done with them, and the really important part actually comes with this, because he'll tell you what we did and what was done and what they can do. Hand it over to you, Eric.
Okay. My name's Eric Widen, CEO and co-founder of HBI Solutions, and so really excited to be here today and really excited about our partnership with Bumrungrad. And so just a little bit about HBI, and I'll talk a little bit about the company, but really talk about how you use data to basically deliver better healthcare. Whether it's big data, deep learning, machine learning, data analysis, data analytics, it's really about how do you use the data to take care of patients better in a more cost-effective way. And I'll talk about how we approach that and work with different partners. So we are a technology partner with InterSystems. We work both with the HealthShare product and the TrackCare product lines to generate these data insights. But our whole philosophy as a company is to really take data to help people and patients get healthier and to help clinicians proactively take care of patients by giving them prospective information on what's going to happen to the patient, both economically and financially, but also clinically. And this helps you tee up proactive care to deliver better health care in a more economic way. And that's all we do as a company. We're strictly healthcare only. So just what you get with HBI is a product called Spotlight. It's a Spotlight analytics solution. It takes both data to generate and deliver what we call machine learning as a service, and I'll talk a little bit more about that. And it's also, within a production environment, it's basically delivering real-time clinical insights, whether the patient's acutely in a bed or whether the patient's at home and needs to be taken care of from a more population-focused. These insights are delivered in both of those venues, and I'll talk a little bit and expand on that. But with HBI, the core of the team is it's data scientists and engineers that are literally implementing, managing, and supporting our clients as part of that, and we help people onboard our technology to be successful with it through consulting. So we think about the continuum of care basically in two ways. There's two basic modules you get within Spotlight. One is around acute episode management. So patient deteriorates, needs to enter the hospital either in an emergency or the inpatient setting, and you want to manage them pre-admission, during the admission, then in post-discharge. And we think about that acute episode management as one sphere of care on the patients and delivering clinical insights for that. And then the second module is really around population health, right? You own a population of patients, you own their economic and their clinical outcomes, and how do you care about them holistically and really keep them healthy in the home as part of that. And then in the US, we're mostly focused on the US, but we are starting with Bumrungrad and in China starting to venture out more internationally, but we have a diverse array of different buyers in the US healthcare market. We work with health systems or hospitals. And on the right-hand side, there are ACOs in the US, which are called accountable care organizations. It's kind of a stepping stone for a provider to learn how to take care of patients from a population health standpoint. We work with health information exchanges, which basically aggregate data across a geography to create a longitudinal medical record and across a geographic area that any one provider can then understand that longitudinal data from a patient standpoint. And we work with Medicaid, which is a health plan for low-income patients, and we work directly with health plans. So different buyers using predictive analytics in different but also similar ways. And so just a little bit about our partnership with InterSystems. So we've been technology partners with them since 2016. We released an InterSystems Cache version of our software in 2017. And then today we're live on over 40 million patients with them, and we're actively working with Bumrungrad using their data for that. And so the clients across the bottom here are a mix of health information exchanges, a Medicaid plan, and also a provider, all using InterSystems technology to care for patients, and then Spotlight's bundled within that technology to generate the insights I'm about to talk about. So just a little bit about why the credibility of HBI. So live on 40 million patients. We talk about Spotlight. It's running today actively in real time on over 40 million patient population. We back our solutions with publications. We're very research-oriented, so a lot of the predictive insights that we talk about today have been published in peer-reviewed journals as part of that. And then our core capabilities that drive the analytics into both the episode and the population management modules are what we call machine learning as a service. And what that means is for every client, we take their data, analyze it through machine learning, and develop specifically tuned and calibrated models on their data in their population. It's very important because patients here in Thailand are different than patients in China and different than patients in the US, and also the data is different, right? So by doing what we call custom machine learning as a service, we can pick up those nuances, those important features, those important data elements that actually drive risk in these individual patient populations as part of that. And we use basically any and all available data, whether it's electronic health record data or claims data from an insurance company or a clinical note using natural language processing on that. We're kind of equal opportunity with the data. Our philosophy is give us what data you have, and we're going to develop the best predictive analytic insights on your data and your patients. So just a little bit about the two modules. The way we think about the acute episode module, even from the time a patient deteriorates and enters the acute setting, if they're scheduling an elective appointment, at that point in time, we know their age, their gender, where they live, their comorbidities, their chronic diseases, their historical utilization, if this information is available. Those are very important features where you can predict, even at the time of scheduling an appointment, what they're going to cost, on average, what their predicted length of stay is going to be, and their likelihood to have an adverse outcome during that event. Are they more likely to develop sepsis during the episode? Are they more likely to have a post-discharge event after the episode? It's going to tee up your approach to care at the time of scheduling, so you can think about these things right when the patient enters. And then once you get into the acute episode arena, right, we're predicting in real time sepsis, falls, infections, hospital-acquired conditions, likelihood of 30-day readmissions, all kind of as a new clinical result within the electronic health record and also within track care, right? So this can be, they're running every 10 minutes to 15 minutes as a new clinical insight that's basically analytically derived in real time. So as vital signs come in, labs come in, you're combining that type of information with the information that you know at the time of scheduling to start creating these insights at that. And then when the patient transitions back home, it's a very important transition period for a patient, right? And the more critically ill patients are more likely to have adverse outcomes during this transition. It's important to understand which patients are more likely to have an episode post-discharge, and you've got to think about those post-discharge care plans at that. So this is a bundle that we're offering as part of the acute episode management module. And just a little bit about, so the publications, you can look at the publications on our website, but it's an example of the acute early warning system predicting mortality every 10 or 15 minutes while a patient's in a bed. These are insights being driven to understand, is this patient going to deteriorate in the next hour or a couple hours while they're in a bed? And then on the population side, think about this as patients at home, but could have events in the future. We can understand what they're going to cost in the future. Are they likely to show up in the inpatient setting or the emergency room setting? Are they likely to develop a chronic condition like hypertension or diabetes, chronic kidney disease if they haven't developed it yet? Are they likely to have a high-cost, high-morbidity event like a heart attack or a stroke, right? So you're going to manage patients from an ambulatory standpoint, and they can be at risk at home. And the goal here is to keep them healthy in the home and manage them economically and costly from a disease and condition standpoint. And this is an example of the types of models that are basically live in production today. So we predict what they're going to cost in the future, likelihood for an ED visit. You can see the disease events. These are typically, can be repeatable: heart attack, stroke, mortality. And then these are the types of chronic conditions we're predicting on patients today. And this is an example of a publication for chronic kidney disease. So likelihood for developing CKD if you don't have it today. And just a little bit about the workflow of how this would work in this example from a track care standpoint. So to leverage the data that you have, right, I'm going to talk about both how we do machine learning, but also how this would work in a production environment. So what we'll do is we'll take the data source, in this instance track care, and we look at longitudinal information. We typically want to take 3+ years of a patient population's information, including the inpatient, outpatient, emergency utilization and history on a patient's. We take that initial data set, de-identify it, and then conduct what we call machine learning as a service on that, and run a couple of series of what we call blind prospective testing to tune and calibrate the algorithms to that data set to make sure that they're going to be accurate in a production environment. And the output of that process is basically models that are deployed back in the production environment. So once the models are deployed, as new information comes in real time on the patient, basically information comes in, then the predictive engines would run and update the risk on those patients, both from an episodic standpoint, also from a population standpoint. The same data set can be used for both purposes. And those risk insights are integrated back into the workflow engine, into track care, and also can be viewed in an aggregated visual view as well. So I'm going to show you an example now of specifically for sepsis and how this would work for sepsis to look at the entire population within a bed and then drilling down to a single patient that's at risk for sepsis as a single example in what we're experimenting with Bumrungrad today. So in this visualization here at the top in the upper right, you have 185 patients in a bed right now. It's your active population. It's like a bed board. These patients admitted, not yet discharged, and they have different risks during this episode that you need to manage. And what you're seeing in these distribution charts are basically distribution of risk for the 185 patients that are in the population. And our approach and methodology is basically we score, the risk score, everybody gets a score between 0 and 100, which equates to probability of the event. We basically tune and calibrate the models so that when you look at a risk score, it's probability of having that event. So if someone has 20, they're 20% likely to have that event, 40% likely. And so these distribution charts represent the number of people out of the 185 from low to high risk for different events in the hospital. So you're looking at number of people distributed from low to high risk for 30-day readmission, for mortality, for sepsis, and then predicting length of stay in the hospital. So it gives you an understanding. Once a patient's admitted, these statistics are calculated so you can look at how many people do I have at different risk levels in the bed right now. And what we want to do is focus on sepsis risk. So I blew this one up and we said, okay, most people are less than 1, not likely to have sepsis during the episode, but you can start seeing number of patients, 30 plus, that are elevated, if you will, for having a sepsis event during this episode. And we say, okay, we want to drill into this patient population to understand which patients are they, and how do we drill into a single patient that's at elevated risk for sepsis and target them for proactive care. And for sepsis, fluids, antibiotics are standard practice once you know someone's trending the wrong way for sepsis or is in septic to have a positive outcome on the patient. If you miss that window, the patient could deteriorate and have an adverse event. So here you're looking at basically a bed board, right? And this is, each row is an individual person. These are blinded patients. It's just dummy data for our demo system. And it's sorted from high to low for sepsis scores. So we see some people, we saw most people are below 1, but now we see some people with a score of 27. And we say, okay, these people are 1 out of 4 of these people will actually have sepsis during this episode given the features that we know on this patient. And you can see some other scores. So all the scores would be arrayed basically on a bed board like this. So it's sorted from high to low. And we want to drill into the first person that's at the most elevated risk for sepsis. And then we drill into this individual person. Now we're in a single record for a single patient active in a bed. And we focus on this patient because of their score for sepsis. But you can also see they're elevated. Red means elevated from the norm of the population. Also elevated for a 30-day readmission. Has gone beyond their predicted length of stay, and so it's elevated for length of stay. But we're focused on the sepsis score, and this trend chart you see on the right here basically is their score since the time of admission. These are running every 10 or 15 minutes on a patient in a bed, and something happened in the most recent hours to put them in an elevated risk. And so you can understand this trend, and again, these insights integrated right back in the electronic health record. So you can see this person's bumped up recently, and we want to say, okay, what's driving this person's risk, right? So we're very transparent with the models. It's not a black box. When we develop the algorithms, as they run in the production environment, we're going to show you and unveil all the features, all the data points on a patient that the algorithm picked up to put them in an elevated risk status. And so we can see for this patient, and this is sorted by odds ratio to understand the higher weighted features for this patient. We can see here that the most recent laboratory results are the most important indicators that have put this person into an elevated risk for sepsis. This allows the clinician to understand what's going on with the patient, helps to provide these clinical insights to the point of care to help them act on the patient. So this is everything we're deriving analytically on these patients. And then they would use their local norms for care to care for these patients. All right, thank you.